Good afternoon, colleagues, and thank you for joining us for this webinar titled PrEP in HIV Clinical Practice in the Bahamas, Lessons Learned for the Caribbean. I am Dr. Shanti Singh Anthony, and I am the Knowledge Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS, PANCAP, based at the PANCAP Coordinating Unit in Georgetown. Let me extend a warm welcome to you on behalf of PANCAP and PANCAP's Director, Mr. Derek Springer, and thank you in advance for joining us. At this point, I'd like to share with you a few housekeeping notes. Firstly, our mics are muted, and so if you have questions, I ask that you type these in as the webinar progresses. We will take your questions during the question and answer segment after the presentations. Secondly, I'd like to inform you that we're recording this webinar and will share the recording on PANCAP's website for the benefit of the partnership. And finally, you will receive in your emails a post-webinar evaluation. I encourage you, please, to complete and share your thoughts and impressions. This will be useful for us to enhance future webinar experiences. This webinar this afternoon is a follow-on to the PANCAP K4 Health South-to-South Learning Exchange that was held on May 6th to 10th in Nassau, the Bahamas, where National AIDS Program managers, clinical practitioners, and civil society representatives from Jamaica, Guyana, and Trinidad and Tobago experienced firsthand pre-exposure prophylaxis, or PrEP, implementation practices in the Bahamas, and were able to think through lessons that can be applied in their own programs. This webinar is also intended to build on the PrEP conversation in the region, and particularly for other National AIDS Program managers, clinical practitioners, and civil society representatives who will be participating in the upcoming PrEP Share Fair in Barbados on July 15th and 16th. Today we have two presentations. The first presentation will be done by Dr. Nikkiah Forbes. She is the Director of the National HIV, AIDS, and Infectious Disease Programme at the Bahamas Ministry of Health. She is a consultant at in infectious diseases at the Princess Margaret Hospital and Doctors Hospital, and an associate lecturer at the University of the West Indies School of Clinical Medicine and Research, the Bahamas. Dr. Forbes is a highly skilled clinical practitioner who embraces the science and clinical practice and at the policy level, and in this instance has led PrEP implementation in the Bahamas. She will provide us with an update on PrEP implementation in her program. The second part of the presentation will be done by participants who attended the South-to-South Learning Exchange. We have Ms. Angeli of the Family Planning Association of Trinidad and Tobago, who is doing an excellent job on sexual and reproductive health services, family planning, and HIV, and is continuing the dialogue with stakeholders in Trinidad to commence PrEP delivery. We also have with us Dr. Abiola Jacobs, who is the Director of the National Care and Treatment Center, the largest HIV treatment site and really a center of excellence for HIV management in Guyana. They will both share their lessons learned from the Bahamas and how they will apply these lessons to their respective programs. At this point, I hand you over to Dr. Forbes, who will now do her presentation.
Thank you, Shanti, for that warm introduction, and thank you to PANCAP for giving us this platform where we can continue to discuss HIV pre-exposure prophylaxis and how it can benefit the Caribbean region. It's just another HIV prevention modality, and I think it's really important for us to establish these programs in our country and in our region. So we have started a PrEP program in the Bahamas, and that started in 2016. So I will share a bit with you about what it is that we did and how we continue to see this program rolled out. So today I will talk a little bit about the HIV epidemic in the Bahamas and why HIV prevention is so very important when we look at our fight to end AIDS, and why we need to include PrEP as just another modality in a combination prevention approach. I will just briefly talk a bit about the science of PrEP, but this builds on our previous webinar on PrEP, and we've had a lot of opportunities to discuss PrEP in our regional meetings, and we'll have yet another opportunity in Barbados soon. I will tell you some of where the rubber meets the road challenges with implementing PrEP in a developing country, and what are some of our lessons learned, and then I'll take some questions after the other presenters. So the HIV epidemic in the Bahamas started in 1983. And as you can see, we are an island nation. And at one point, we had a very high prevalence of HIV, just under 4%. So the UN model reflected that there were 5,287 persons reportedly living with HIV or AIDS in the Bahamas in 2017. And like a lot of Caribbean countries, we also have a concentrated and generalized HIV epidemic. In the general population, the HIV prevalence is 1.3%, but we know that there are groups that are at risk for HIV infection and the prevalence is higher. For example, the MSM prevalence is 19.6%, according to a BBS study that we did in collaboration with the CDC in 2015. And there were 151 new HIV infections in 2017. This is the trend of HIV infections over time from the beginning of the epidemic in the Bahamas from 1985 to present. And so you can see here that there was a peak in 1993 with just under 800 cases that year. And we've seen a slow progressive decline in HIV infections to a low of 116 in 2016. And we reported 151 cases in 2017. So regionally, we're also seeing a decline in HIV infections. And there are a number of things that can account for this. Certainly, we had the rollout of highly active antiretroviral therapy in the 1990s. And we know that treatment is prevention. And we also prioritized HIV prevention modalities, including outreach and testing and getting people to know their status. And you can see that this has borne fruit, and we have seen a decline in infections over time. And then males and females, you can see in the line graph that the dark orange is female and males. They have similar trends over time. Now, we know that HIV prevention has to be a combination approach. And here, this is a pictogram that is probably familiar to a lot of you. There are biomedical ways to prevent HIV, structural ways, and behavioral ways. And PrEP just fits into this neatly. So just to recap, there's condoms and lubricants. There is treatment as prevention. There is voluntary male circumcision in places where there is high HIV prevalence. Needle and syringe programs in places where HIV is transmitted primarily or additionally by IV drug use. And then there are things like addressing the social determinants of health and risk reduction. But we must remember that to effectively prevent HIV, we must use a combination approach because they are layers of risk, and there is no modality that is 100% effective and efficacious. So we should encourage a combination prevention approach, and PrEP is just one part of this. Why do we need PrEP? So there are still some PrEP denialists, and we have to consider that despite the work that we have done to end AIDS, we're still seeing a significant number of new infections annually. So 100 per year is still quite a lot. Our population in the Bahamas is just about 380,000. And in some locations, HIV infections, the rates have remained stagnant, and HIV infections are also increasing in some locales. And so we need to think of other strategic ways that we can prevent HIV infection. I also want to draw a reference to the fact that the HIV treatment cascade in the Caribbean, we know that we've diagnosed just about 74% of persons that are living with HIV. But certainly there are about 25 to 27% of persons in the Caribbean that are HIV infected that have not been diagnosed as yet. And so without treatment, viral loads may be high. And we know it's a detectable viremia that leads to transmission. And so we've got to think of modalities to protect the persons that are most at risk. And certainly high prevalence populations or at-risk populations, we need to think about those persons most at risk and how we can arm them effectively to prevent new HIV infections. And so PrEP is something that can be strongly argued for in places where it has not yet been implemented. So HIV PrEP is an oral prevention strategy in which a person who is HIV negative but at high risk for HIV infection takes antiretroviral medication regularly to prevent new infection. And currently, the only drug that has been FDA approved for PrEP is tenofovir emtricitabine, and this has been approved since July of 2012. And there are some added benefits, but it certainly has changed the conversation on HIV prevention. It is a reverse transcriptase inhibitor. It's a single dose co-formulated pill. It has a very good safety record. It's potent, well tolerated. It has a long half-life of more than 48 hours, and it penetrates vaginal and rectal tissues very well. So overall, there have been many studies about PrEP. There's available evidence. There have been more than 18 studies, and there are also abstracts from conferences and posters. And so essentially, there is a meta-analysis that's available, freely available online, that looks at the efficacy of PrEP. And so we know that PrEP works when it's taken without a doubt. And what we know is that those trials in which there was high PrEP use, those trials demonstrated that with high PrEP use, HIV could be prevented. The relative risk is very, very low. If someone is taking PrEP all the time, it's 0.3%, and it's very statistically significant. So across populations and with different regimens, PrEP significantly reduces the risk of HIV acquisition, and there are very few adverse effects. It's very similar between PrEP and placebo. And so we know that people at substantial risk of HIV infection should be offered PrEP, and it should be a part of an additional prevention choice in a comprehensive package of services. So I'm just going to say a word briefly about PrEP. It's not a magic bullet. You need trained providers, and to initiate PrEP, you need providers who can do the PrEP consultation, but very, very high up in that list of after eligibility is the patient's willingness and commitment to take PrEP, because at this time, it's for daily use, and there will need to be some lab studies and tests to ensure that the patient is HIV negative, that they don't have STIs, that they don't have pre-existing renal disease, because PrEP is a prescription medication and there can be adverse effects. And it also does need to be monitored. Every 3 months, your patient will need to be seen to ensure they don't have an HIV infection, a newly acquired HIV infection, that they haven't developed a side effect. You have to reassess them for their levels of risk and their willingness to take PrEP and be willing to modify. But those slides are available in a previous webinar that we did that's available on the PANCAP website. And so we took into account all of these things. And we knew that we had to ethically provide PrEP for our patients. And we had strong will to do this. And so we actually started to do this in 2015, but we introduced it into our National HIV Prevention Guidelines in June of 2016. And so at this time, we're offering PrEP to those persons who are most at risk, and it is tenofovir emtricitabine, and it's for HIV negative individuals at substantial risk for HIV infection, including a recent sexually transmitted infection, a high risk partner, having multiple partners, being a part of a at-risk population, certainly serodiscordant couples, MSM with risk, transgender women at risk, commercial sex workers at risk, and we are offering it as a part of a combination prevention approach. So at the time we added PrEP, that completed the entire set of HIV prevention modalities that were available in the Bahamas, and we were highlighted in the HIV prevention in the spotlight in 2017 for having a fully comprehensive HIV prevention package. So how is it that we went about implementing PrEP? So I will tell you that it was a process. We did not have to reinvent the wheel because there is a fully available rich medical literature that demonstrates that PrEP is beneficial and effective in a myriad of populations. However, we had to consider funding and medication procurement. We had strong government commitment to start our PrEP program because PrEP is free of cost in the Bahamas to consumers. And we also had to consider procuring the medication and having stocks of the medication, and keeping in mind that Truvada FTC is also a part of HIV treatment. And so we would have to ensure that our medication arsenal was stocked so that we would not have stockouts of medication for those persons needing tenofovir and emtricitabine for HIV treatment. It required training of healthcare workers. We've had multiple trainings with our clinical team. We have a PrEP expert team with a nurse, a counselor, physicians who have been trained to provide PrEP. And we also had to consider trainings for primary care physicians in the front line in primary care, internal medicine, family medicine, the general public, and our CSO partners, as well as people living with HIV. So we've had multiple opportunities where we talked about PrEP in physician trainings, in small focus groups, in talks to the general public, in talks for our medical school, and in the papers whenever we can have the opportunity to really encourage persons to know that PrEP is available and inform about PrEP. And we were so convinced about PrEP that we actually did include it in our prevention strategy for our HIV strategic plan that was drafted for 2016-2021. We have a lot of rich partnerships in the Bahamas. We have quite a few civil society partners, and we have their partnership to navigate clients for PrEP and drive the PrEP demand. And of course, this cannot be done just once. There has to be an ongoing wave of training and refinement. So prior to 2016, we did have some off-label PrEP usage. Persons were given PrEP. About 9 persons who were a part of serodiscordant couples did receive PrEP, and we have started just about 75 persons on PrEP since the initiation of our PrEP program. And so I can tell you that it was a slow rollout, but we are continuing to see more persons initiate PrEP and more persons on PrEP as time goes on. And it's gaining traction. So more and more persons are asking about PrEP. They're coming in to seek PrEP, and we're starting more and more persons at risk on PrEP. And the majority of these persons have been in the age group that are 20 to 49, and a lot of them are MSM at-risk populations and serodiscordant couples and patients that are seen in our comprehensive clinic. But the work is ongoing, and we also do need to consider off-label PrEP use, such as PrEP on demand. And so the IAS does have PrEP on demand in their prevention guidelines, but it's not quite made other prevention guidelines yet. But it is something that we should be willing to discuss, and I'll talk more on that as we continue the webinar. So after rolling out PrEP just about 3 years ago, I can tell you what we have learned thus far, and I'll start with the strengths. So we were lucky in that the commitment and will was strong to start PrEP. So PrEP has been around for a while. It's been FDA approved since 2012. And I do think that it has to, it's a human rights issue. We have to be able to arm people to protect themselves, and PrEP is just another way of preventing HIV. So we were fully convinced and had strong that funding was paramount. We had 100% support of our government, and we also had strong civil society partnerships. Clients were asking about PrEP. The CSO partners were willing to partner with us to link patients to care, and they were very excited about offering this new modality, especially in the work that we did with MSM and the Men's Health Project and the work with transgender women. They were very excited about having this program start. And we also had trained physicians that were positioned in a lot of strategic places. So HIV in the Bahamas, the care had been centralized for a number of years, and we certainly do have our largest treatment site But we have a number of primary care physicians that have worked with us over a number of years, and they've been able to take their knowledge and training and start clinics outside of that are decentralized to allow patients to get care in non-traditional sites and also outside of our regular hours. And so they're really strong proponents of the PrEP program, and they have been strong partners in helping us to provide PrEP as well as other HIV treatment care and support services. And so those were some of the strengths that we had that enabled us to start this quickly. There are barriers and challenges, however. And so, as we know from other chronic medical diseases and from those people who have HIV infection themselves, adherence has been challenging for us. And retention and care, even for HIV patients, has been a challenge in our program because we don't necessarily have a very good pill-taking culture. And so we have found that patients are not necessarily continuing on PrEP, and that can be for a number of reasons. A lot of patients are interested and excited to start, but remember, PrEP is not indefinite. It's while your season of risk is there. And so sometimes some things change. For example, the patients that are serodiscordant, if their partner achieves viral suppression, sometimes they no longer want to take PrEP. Sometimes the patients are having side effects from the PrEP, or they say that they would just prefer to use condoms. And so we are finding that a number of persons are discontinuing PrEP and are not continuing in PrEP, but we are starting new persons. I would follow up to say that you really need to assess PrEP readiness. That's crucial before starting persons on PrEP. And patient education is very important, as well as the reassessment in the clinical follow-up. Because certainly if they're not willing to take PrEP, you've got to look at their other layers of risk and really counsel on other HIV prevention modalities. And then there really is stigma. And even though, if you think about it, PrEP is really for people who are HIV negative, that doesn't mean that the stigma around HIV and HIV medications do not exist. So in some cases, there has been expressed fears about stigma, about our PrEP role. That is the register for persons on PrEP who will see that these persons are on medications and they're concerned because the medications are for HIV, and sometimes there's stigma for sites that are offering PrEP. So the truth of the matter is sometimes PrEP is offered in HIV treatment services, and there is stigma around those sites with people concerned that that this is a care site for persons that are HIV positive. And so we really need to encourage primary care providers and other persons to feel comfortable providing PrEP in the primary care setting and also in non-traditional settings. But then that would lead me to my next possible barrier, and that is physician awareness. So up to 4 out of 5 persons in some locales, that is doctors, do not know what PrEP is. And you can do this little pilot where you are. You can ask doctors, do you know what HIV PrEP is? And some doctors don't know. And when we have done trainings, we have had persons express to us that they're not comfortable in providing PrEP, and maybe that's something that HIV expert providers should do or are better at doing. And certainly there are missed opportunities for PrEP. So if you think about persons that are most at risk, it's going to be the vulnerable, and you may not have reach to those persons. And then certainly there can be serodiscordant couples, some of which may not have disclosed or feel uncomfortable disclosing, or they haven't brought their partner in, or the partner hasn't come in for testing and counseling. So I'll say that there are still missed opportunities for PrEP. And even when you go back and look at logs of people who have seroconverted, we've missed opportunities to provide PrEP for those persons. And we still have challenges with reach and the most vulnerable, for example, youth, and that is linked to age of consent for services and whether or not persons will feel comfortable entering into traditional care sites. But it's still early and we do not really know at this point in our setting how PrEP will have impacted new HIV infections. I don't think that these barriers are insurmountable. And so I would say that these things can be addressed if you will successfully implement a PrEP program. You can programmatically consider drug costs, as well as PrEP monitoring and other costs. You can counsel your patients on adherence and their willingness to start PrEP, and counsel them at each visit. And you can get around stigma by offering PrEP in non-HIV care sites. So it's really going to be important to do trainings for your primary care doctors and in other settings. And then to improve reach, partnerships are very important, and be willing to see persons outside of the healthcare site. And there are a lot of tools that can be utilized, such as the WHO PrEP support kit and the toolkit, and there are collaborations and technical assistance needed. I think as a region, we need to help each other so that we can strengthen what we're doing, especially in light of declining donor funds. And then, of course, you know, where do you convince persons that are high-level persons to implement PrEP in your setting? You have to really be persuasive, and there's no doubt that PrEP is cost effective. It's not very expensive, and it's definitely cheaper than having a new HIV infection. So barriers to PrEP do not just exist in our countries. PrEP remains underutilized. Even in the United States, you can see that there are regions that have a high unmet need for PrEP. And so this map, I borrowed it from Clinical Care Options. You'll see a map of the United States, and you can see here that in 2016, the rate of PrEP usage, so you can see the country divided up in regions, the rate of PrEP usage was 2 times higher in the Northeast than the West, South, and the Midwest. However, there is a high need for PrEP in the southern United States. And so more than half of the PrEP users were only in 5 states: New York and California, Texas, and Florida. And so we know that PrEP is needed, and there are places that certainly have a need for PrEP, but PrEP access is poor. And so I've just put a little key that there are things that can help us with this globally, that is PrEP awareness, evidence-based, driving demand, advocacy, funding, planning, and partnerships. So there is a potential role for PrEP in the Caribbean too, and we should strengthen this intervention as a part of the prevention approach and consider it especially for hard to reach vulnerable populations. And it may assist in the reduction of new infections, and it has to be a strategy for ending AIDS, especially since we know that over a quarter of HIV positive persons are still not diagnosed in our settings. And we do have strong partnerships, and that can help to facilitate demand generation and the scale up of PrEP in our region. And PrEP has been around for a long time. It's now, 7 years old. I need to update the slide. But we really need to ensure that we can implement this successfully where we live too. And so I will end now because I'm only supposed to take 20 minutes out of the time allotted. And so I'll summarize that HIV prevention is a combination prevention approach. There is no standalone HIV prevention strategy that's 100% effective and efficacious. And so PrEP is effective if it's used as recommended and adherence is paramount. And PrEP is just an additional HIV prevention option in the Bahamas that we rolled out formally in 2016. But starting PrEP, I'll tell you, it was a process, and it required partnership at multiple levels, and that helps for the successful implementation. But there were strengths like strong political will, technical will and commitment, support for funding. There was demand and partnerships, and we had trained healthcare workers that also were very interested. And we do have barriers such as poor adherence, stigma around HIV, and PrEP physician knowledge and comfort. But there are challenges in other settings, and PrEP is still underutilized in many places. However, there are strategies to address these barriers that can be effective. And there's a continued need to prioritize HIV prevention work as a part of our efforts to end AIDS. So I'll end with that, and I will hand it back over to Shanti now.
Thank you so very much, Dr. Forbes. Thank you for reminding us of the science, which is very strong. And thank you for, again, making a very convincing and clear case for PrEP in the Caribbean. At this point, I'll hand you over to Miss Angeli, who will be sharing her experiences from the South to South Learning Exchange that took place in the Bahamas. Over to you, Angeli.
Hi, pleasant good evening, everyone. So my name is Angeli Chotalal and I'm representing the Bahamas. So I was asked to present basically 3 slides, and the first slide being on what I found was surprising about the whole PrEP treatment in the Bahamas. And I have to say what I found surprising was basically everything. Trinidad and Tobago is very new to the idea of PrEP. It is not openly practiced in Trinidad and Tobago. Persons that use the PrEP, they buy the medication online. So it's something that is not really a conversation starter or even conversed openly. However, in my trip to the Bahamas, I found one thing to be really surprising besides the everything, and that was the level of coordination. It was amazing to see that there was just one cohort of persons providing services for everything that was related to HIV. And when you look at PrEP, just monitoring, counseling, identifying persons, follow-ups for PrEP, persons on PrEP, was just as time-consuming and task-oriented as treating persons who are HIV positive. However, yet the response by the Bahamas team was well organized. It was very effective and very efficient in how it treated with all aspects of its HIV response. And to me, that was very, very eye-opening. It was very surprising. And, you know, I wish I could have stayed there for a week more just to be involved, just to see how it all works. Because as an organization, you wonder, how are you going to be able to do all of this thing? And here was the Bahamas doing it so successfully. Another thing that surprised me was the stakeholders, that all those that were involved in the HIV/AIDS prevention and response were the faith-based organization, the CSOs, and the Ministry of Health. And the level of coordination between all 3 was very evident, because wherever we went somewhere, you saw where the CSO was actively involved. And of course, the whole response to the HIV treatment and eradication was supported by the Ministry of Health. Then I had to discuss on our lessons learned and how we can use this. So one thing that really struck out throughout every single day that we were there was the CSO participation in the response to the HIV. And these persons are very, very key, because the persons that require PrEP, we often find them there are a lot amongst the key populations. And key populations are not very trusting of the general public and healthcare providers. So we saw where the CSO persons that represent the civil society, as well as the faith-based organizations, were very key in trying to start and to continue in the implementation of PrEP. Another lesson that we saw that would be very important is to ensure that persons that start PrEP adhere to it, because like the Bahamas, Trinidad and Tobago also has a culture where they don't like to take pills. They would prefer an injection to get rid of everything, but that's not doable in terms of the PrEP just yet. So how they were able to ensure that persons were adhering, and that counseling, the level of counseling, the level of testing, and everything that was done necessary to ensure that persons were adherent to their treatment was very, very impressive. And another thing to consider was the resources. FPAT is an NGO, so at present we do not have the support of the Ministry of Health in implementing PrEP. So whatever resources we need, we have to consider sustainability, because as an NGO we rely on funding, but we do not want to be in an instance where, because of the political and economic climate of the international world, smaller countries are affected. And as a result, we don't want now that where funding is ceased or decreased, persons who are on PrEP or who wish to access PrEP would be denied. So we have to think as well in terms of our resources, how we're going to get them and how we are going to make it sustainable so that we don't have an abrupt cessation. So what FPAT has done so far since our last exposure to the PrEP implementation. So my work plan for FPAT was that first we were to have a focus group meeting involving the CSO. So that was already done, and we, in fact, it has been an ongoing conversation. And I'm happy to say that we have had the conversation, and we are now into our second step of our work plan, which is the feasibility study. The feasibility study is actually to determine how many persons would actually be interested in PrEP, because we do not just want to start something that doesn't have a favorable response. Also, because we're thinking about sustainability, we're also looking into would a person who wants to go on PrEP, wants to start PrEP, be willing to pay for it. So currently our feasibility study is it's on its way, and it's going to take place during the Pride Month in Trinidad and Tobago, which is June 22nd to July 29th, which is that little calendar of events that you see on the slide. So during this month, the information will be provided about PrEP, and a study will be done as to whether persons are interested and if they are willing to pay for PrEP. So this will help us in our decision-making process to determine whether or not we can successfully implement that PrEP and continue along that way. Once we have that information, then we will be able to prepare our draft proposal so that we can start the implementation of PrEP and have the discussions with all the stakeholders such as Ministry of Health and the private sectors, the FBOs, the CSOs, and we can say yay or nay to the implementation of PrEP. But we know for a fact that out of the 700 persons that we have already distributed the study to, 250 persons are capable of paying for PrEP. But we're still awaiting the response because we haven't gotten back all of the responses. I thank you very much. Dr. Singh Anthony, back to you.
Thank you so very much, Angeli. That's really very exciting. Good, really good progress by FPAT, and we do look forward to hearing more from you. This is, again, like I said, really very exciting. At this point, I'll invite Dr. Abiola Jacobs from Guyana, who will share a little bit of the lessons that they have taken away from the Bahamas and are really exploring so that they can strengthen what's happening in Guyana in relation to PrEP. Dr. Jacobs.
Good afternoon, everyone. I'm happy to be a part of this webinar, and I'm thankful that the Guyanese team were a part of the South to South exchange in the Bahamas, because Guyana is gearing up to get on board with the PrEP guidelines. Now, just some take-home points from Ms. Angie. It seems to me that we all shared the same experiences, but from the Guyanese perspective, what we found unique there in the Bahamas, we noted that the HIV program was similar to that of Guyana. We also realized that the CSOs are vital and they play an integral role in the rolling off of the PrEP program. We noted that for the initial screening for PrEP eligibility, it was actually done by the CSOs, even before the client was referred to the clinicians for further screening and discussions. This approach we found was different from other countries who had initiated PrEP programs, and we thought it was commendable and that it can work in a setting as Guyana, where we have a limited resource. It's you. Also, what were the lessons we learned? We learned numerous lessons there in the Bahamas. What stood out? We noted that for some clients, they preferred the private physician treatment, or really to initiate PrEP in that setting, as opposed to the HIV treatment centers. Again, Dr. Forbes mentioned the whole issue with stigma and discrimination. Also, we found that we were on the right track. The Ghana National AIDS Program Secretariat had already started engaging a major CSO in Guyana, which is the SASOD, in relation to rolling out PrEP. And let me just reinforce something again. We realized how critical it was to really strengthen our ties with CSOs. So we need to work together. Where's Guyana? What progress we made so far after the South-to-South exchange? Well, we know in Guyana we need to break certain cultural barriers. How can we do this? We can do this through the development of a communication plan for the dissemination of information on PrEP to the general and target populations, or what we call our key populations, to the clinicians, like Dr. Forbes said, and the policy makers. Education is power. Now, we know that persons in Guyana want PrEP. Why? Because as a physician at the largest STI site, people constantly ask about PrEP. So I'm happy about that. So what do we have to do? Really push our communication, really sensitize our population. And based on the work plan that we created, we're going to be printing posters so that we can disseminate information, even information tools to these target groups. We're going to be working closer with the CSOs, so that we can all be on the same page. Just as Dr. Forbes mentioned, the importance of training our physicians. We saw the need to do that. Even in my setting, I find, outside physicians are limited in their knowledge as it relates to HIV in the whole. So Guyana has worked on our work plan. We have worked on our work plan. One of the first things we're going to do on the 24th of June, we're going to have a meeting with the key populations organizations. So we can really get to listen to them more, understand what they want, and decide on the way forward. That's it. Thank you, everyone.
Thank you very much, Dr. Jacobs. Again, good progress from Guyana. Dr. Forbes, I'm sure that you must be pleased with what we're hearing from Anjali and from Dr. Jacobs. At this point, I'll commence the question and answer segment, but just to say that there's a poll in progress, and we can see from the responses that 59% of our participants here today are saying that there is no PrEP implementation that's happening in their country. So reinforcing what we all know, there is a lot more work to be done in the region in relation to PrEP. I have quite a number of questions that have come up, and so I will start with the question and answer segment. So Dr. Forbes, to you and to Anjali and to Dr. Jacobs, first question is that PrEP can be perceived as a way to stimulate unsafe sex. Which strategies can be developed to better influence that perception among marginalized groups, such as men who have sex with men? Anyone?
I'll take that one.
I'll take them one at a time, Dr. Forbes, because some of them are a bit lengthy. Yes. So go ahead.
Go ahead. Okay. So I have heard that a lot in terms of arguments against PrEP. So if you go back to the studies in the meta-analysis, PrEP didn't disinhibit behavior. People didn't change their behavior because they were on PrEP. But I always say, studies are not necessarily what happens in the real world. But if you do read the information around PrEP and the information that should be given to the clients, you should counsel the clients, even at the first PrEP interview, in terms of sexually transmitted infections and the fact that PrEP is not a magic bullet. So people can get sexually transmitted infections on PrEP. people can get HIV on PrEP for a number of reasons, and so condoms really should be used with PrEP. That it's recommended that condoms are used with PrEP. We had discussed that in length at our last webinar opportunity when we talked about PrEP, and so clients do need to keep that in mind, and that is why PrEP is not a standalone strategy. It's a part of a combination prevention approach, and so you will encourage persons to know their status, have safe sex, use condoms and lubricants, and that's very important. Additionally, when the clients come back to you, there is a screening for sexually transmitted infections, symptoms, and testing. As a baseline before commencing PrEP, persons should be tested for syphilis and other STIs, and that should be done again in the follow-up visits. And so I can't encourage enough communication, and really there's a huge counseling component of putting persons on PrEP with counseling about risks, safe sex, STIs, and other HIV prevention modalities. So that has got to be a part of it, must be a part of it. But it's not a reason not to start PrEP.
All right, great. Thank you, Dr. Forbes. Next question to you. Which actions will ministries of health and other stakeholders in the Caribbean take to introduce PrEP, especially working with marginalized groups, since stigma and discrimination hinders access to health services for marginalized groups? I think Dr. Jacobs will take that question.
Very interesting question, and that's why I mentioned in my discussion that we're going to move away from the public health access. Patients will be given the opportunity to access PrEP through private physicians or private-public partnerships. So I think that will assist in diminishing the whole stigma and discrimination attached to actually receiving PrEP.
Okay, thank you so very much, Dr. Jacobs. I'll move on to the next question, which is, how can civil society organizations working in the region benefit from training on PrEP? And maybe I can provide a response to that, Dr. Forbes and anyone else, Dr. Jacobs and Ms. Angeli, please feel free to add. Just to say that the South-to-South Learning Exchange that took place in the Bahamas, teams from the different countries included civil society representatives. So we did take into consideration the importance of civil society in working with other stakeholders so that PrEP can be introduced in countries and implemented in countries. We have the upcoming PrEP Share Fair that's happening in Barbados. And again, countries will be going into the PrEP Share Fair with civil society counterparts. Just to say that what we can do from PANCAP's end, we can share, and I'm making a commitment to doing this, we can share the link to the WHO PrEP toolkit. I found them to be really very useful. They're modules for civil society organization, they're modules for primary health care practitioners, they're modules for different categories of clinical practitioners and non-clinical persons. Really very user-friendly, so I'm committing to sharing that as well. I don't know if you would like to add anything on that, Dr. Forbes?
I lost you for a minute there, Shanti. The audio cut out.
Oh, I am sorry. I was saying the final thing that I wanted to do, I'm making a commitment that we will share from PANCAP's and we will share the link to the WHO PrEP toolkits, which I find are very user-friendly, very simple, very user-friendly, and they're toolkits for different categories of stakeholders, so clinical practitioners, civil society organization, and non-clinical persons as well.
Yes, I agree. Those are wonderful resources to have, and they address pretty much every area you will need to have full knowledge of to successfully implement a PrEP program in your country.
Okay.
May I add this one? Sorry, this is Angela.
Go ahead, Angeli.
As I mentioned before, it's very important to have the CSOs involved because of the trust issues. So when we have to implement PrEP, it's very important that the CSOs, persons that interact with the population that is interested in PrEP, that they be trained. Because very often we find that persons aren't aware or they aren't educated on what they are going to use. So it's very important that these persons who are acting on with the key populations, whether it's CSOs or just community representatives or faith-based organizations, that they be trained in what is PrEP, how is it used, and just the whole issue of PrEP and its use. And in such a case of very often with FPAT, when we have these new implementation happening, we often call together members of the CSO and have that training so that they are all trained in what is the issues around the implementation of whatever project we're going to have. So they will be informed on what is PrEP, how is it used, the screening, the STI prevention, how effective it is, the health, the need for adherence. So in that now, they are able to have that interaction with the persons that are going to be the end users, because the end users have more trust and confidence in these CSOs. So it's an important factor to have the CSOs properly trained.
Thank you very much, Angeli, for that. Much appreciated. I have 3 more questions for you, Dr. Forbes, very specific. Please say, is PrEP being provided for free, or is there a cost to PrEP? If yes, what is that cost? The second question is, how is the use of PrEP by clients being monitored? And someone is asking if you can please remind us how many patients are currently enrolled on PrEP.
Thank you very much. So PrEP is free. It's free of cost in the Bahamas. So if you start PrEP in a public facility, there's no cost associated with it, including all the blood tests that need to be done beforehand in the doctor's visits. So keep in mind that PrEP is also provided by some private practitioners, so they can get those PrEP medications for their clients free of cost, and they are to pay forward those medications free of cost. They're to give them to the client free of cost. But sometimes the patients prefer to do the lab tests and the follow-up in the private sector. So if that would be their choice. So there would be a cost for those labs in the private sector if the client opts to do that, but it can be 100% free of cost. How is it monitored? So PrEP, there's a PrEP WHO toolkit. So we are monitoring who's on PrEP, what are their risk classifications, whether they're continuing PrEP, and of course their HIV serostatus. But like Shanti kindly mentioned, there is a PrEP WHO toolkit that includes a monitoring and evaluation kit that can be helpful. And lastly, how many persons are on PrEP? We've overall started about 75 persons since the start of the program, but not all of those clients are still on PrEP. So there are about 40 or so people who've initiated it this year.
Okay, great. Thank you, Dr. Forbes. I have a very specific question to Dr. Jacobs, saying that education is great, education on PrEP is great, but don't you think that widespread dissemination of this option to key populations will then beg the question by them of how they can then get on PrEP?
Thank you. But like everyone said here, it's important that we disseminate that information, because if we're going to engage the CSOs, they're going to come asking for the PrEP. So we need to make sure that they have the necessary information. Never forget that there's an eligibility criteria for PrEP. Not everybody that asks for PrEP will go on PrEP. That's why Dr. Singh and Dr. Forbes mentioned the WHO tools that can be used. Because someone might show up for PrEP, but there are instances where they would not be eligible. Thank you.
Thank you, Dr. Jacobs. I have a few more questions, Dr. Forbes. There's one question that's saying there is no social worker on the team for PrEP, that you mentioned that there's only a counselor. And I think that's in relation to the team that you described. Dr. Forbes, I'm not sure what exactly the question might be, but you may want to react to that. And then there's another question that's asking, how do you manage PrEP with youth regarding legal aspects related to their age?
Okay, so we do have a cadre of health professionals that work within our program. I guess we're lucky in that way because we can offer all these services in one location. We actually do have a trained psychologist and counselor, and we have links to the Department of Social Services, and we do have a social worker that really focuses a lot on the children. I do find this very helpful because, as we know, HIV as a whole and some of the vulnerabilities around it are not just medical, and so it's been a benefit to our program to have these persons available to us. No, a social worker isn't particularly a part of the PrEP specialist team. What we have is specialized physicians that are cross-trained and nurses who also are lay counselors, but we don't have a social worker on our team. I don't actually ever recall reading that that's necessary to have a social worker on your team to initiate PrEP, but I do appreciate that it's helpful in overall HIV treatment care and support. The second question, what was the second question? Remind me.
How do you manage in relation to the legal aspect for youth, the age-related aspect? Yeah.
Yes. So the Bahamas, like many of the other Caribbean countries, there is a gap between the age of consent for services and the age of consent for sex, and so that has been challenging. We've had to find social workers. So in that particular scenario, we've had to reach out to social workers, guardians, and ways that we can offer care to the youth that are most at risk. And sometimes we have to do it in non-traditional ways while keeping account of the fact that the law doesn't support it at this time. But we've been able to work with our team to provide access to some youth.
Okay, so I'll do one final round of questions and then we'll have to wrap up. So I know one of the very earlier question was on the perception of increase in risky behaviors. What I wanted you to share on is, were there any myths and misconceptions outside of what we just spoke about that surprised you when you first started talking about PrEP? And if yes, how did you address these? The second question is, what do you see as some of the key roles of clients themselves in PrEP programs, whether it is for advocacy, whether it is for support to other clients who are on PrEP? And then I have a final question here. So the final question is, how do you deal with clients who are considered lost to follow up? We have a few more questions, but I'll appreciate participants' patience. I can ask the presenters to respond to these and we can send them out via email.
So I'll take those questions. So
Yes,
from since we started PrEP, I've heard a lot of myths, some in country, some other places I've visited, and a lot of them relate to disinhibition, the idea it's going to disinhibit behavior and lead to people being promiscuous. All of these things have been spoken to in the evidence that's fully available. And there are PrEP denialists, and we're going to face that in our work. So I think the only thing you really can do is stick to the evidence, be objective, and be calm but firm. That the proof is in pudding, and the best quality evidence has already been documented. And so you just have to continue to reiterate that. And like I said, you have to be very persuasive in some contexts. I will say that I was lucky. I did not have to persuade anyone who was positioned to block it. I had high-level political commitment and will and 100% support to implement this program, and I'm really grateful that I was able to do that. And it wasn't just the political will, it was the entire team. It was physicians who were excited, willing to help us offer this in their clinics. We did have the support of WHO when we discussed this and made our strategic plan, and they continue to be very, very helpful, offering support as we modify and improve what we're doing. And our civil society partners, they've really, really been there to help drive demand and navigate patients to PrEP. And so I didn't really have a lot of barriers in terms of myths and people that were staunchly against PrEP when at any point, and maybe that was part of why we were able to start this so early and effectively. The role of clients can be very helpful. So when we had the South to South exchange in the Bahamas, we had 2 PrEP clients that really were so generous and came in and spoke to us for a long while and shared their story and their journey to PrEP and how they felt about it. And you really have, I do think that they can be advocates, because telling their stories can sometimes help to convince people, so that we can, yes, PrEP is a program, it's a prevention strategy, but this is impacting people's lives. And like I said, it's a human rights issue. We have to empower people to protect themselves. And certainly those persons who are most at risk for HIV are the ones who are getting HIV in our context. It's going to be sexual, serodiscordant couples, persons that are vulnerable that we know have higher prevalence of HIV. And so we have to offer PrEP, and the clients can help tell that story. And I think that they can really be change makers, and they can really change the story on PrEP in the Caribbean and help us and be our allies when we start this project. Loss to follow up. Now, I need us to keep in mind that PrEP is for HIV negative persons who are at risk, but it's their choice. So one of our PrEP clients said that he'd navigated a few other people to PrEP, and maybe PrEP is not right for everybody. So maybe people are having side effects on PrEP or don't like it. The client that spoke to us said that his friends had change in skin, texture, color, or was feeling nauseous and decided it wasn't for him. And I had mentioned earlier in the presentation, there are serodiscordant couples. Maybe the partner has reached viral suppression, or maybe they prefer to use condoms. And so this is not like the loss to follow up when we talk about people who are HIV positive on medication, and how we are for many, many reasons, including public health reasons and for their own health, are actively seeking that. You have to listen to your client at the end of the day, and you cannot force them to take PrEP. I think our client had also mentioned that you have to offer it as a prevention choice. You have to make sure that the information is available. You have to make sure the modality is available. But if your client chooses not to take PrEP, you have to respect that, and you have to listen to the reasons. They may change their mind later on. Now, remember, the other thing with PrEP is that you can't prescribe more than 3 months, because there needs to be a follow-up after 3 months of initiating PrEP to ensure the person is HIV negative, that it's being taken properly. And so if you haven't followed up in 3 months, you should no longer be on PrEP in that context. I hope that provides some clarity for that part. But you should certainly reach out to them and follow up and determine, is everything going okay? You haven't come back for your checkup. We have been doing that.
Thank you very much, Dr. Jacobs. And I have one final comment. I'm sorry, Dr. Forbes, and I have one final comment from Dr. Jacobs.
Just to reiterate what Dr. Forbes said, I need us to understand that PrEP is not only offered to the key populations. If we have patients of the general population that are serodiscordant couples, they can benefit from this prevention strategy also. And that is an approach that Guyana can take. Thank you.
Colleagues, this brings us to the end of our webinar. I wish to extend a really big thank you to our presenter, Dr. Forbes. Always a pleasure working with you. Thank you, Ms. Angeli and Dr. Jacobs. Very insightful presentations as we continue to build a PrEP knowledge base and increase access to PrEP in the region. Thank you, colleagues, for participating. I trust that you're all better equipped to advocate and to work collaboratively with stakeholders in your programs to advance access to PrEP. As a reminder, the webinar was recorded and will be shared on PANCAP's website. Also, please complete the post-webinar evaluation. We will highly appreciate your feedback. Lastly, I encourage you to stay engaged with the regional response. Look out for the outcomes and decision of the PrEP Share Fair in July in Barbados. Follow us on social media, Facebook, Twitter, and YouTube, and visit the PANCAP website for more information on the regional response. Join us for our next webinar on Tuesday, the 25th of June at 1:30 p.m. as we provide technical assistance on writing good abstracts for the Caribbean Congress on Adolescents and Youth Health. Thank you all and have a good afternoon.